socioeconomic arguments and continues to do so. Thank you so much, everybody. Move on to the next slide. So just to get a sense also of the sector you're from, so these are the choices. For other, if you could write in the chat box, Anna's going to line up the poll for us.
You're going to love this. It's a good thing we have copies because I've tried multiple times and I can't connect. But we have audio and we have slides. We just don't have a chat box. No. Yeah.
That who's speaking about the chat box? I don't know if it's a matter of just moving the size of the screen a little bit or moving it onto a bigger.
Yeah, we are.
Thank you very much. So we've got public health frontline well represented, college universities as well, the healthcare sector in general, that's great, which is where our guest from Health Quality Ontario has come from. Thanks very much, everyone. And Anna, I'll move on to the next slide. So those of you who are following, this is me, and I'm a knowledge translation specialist with the NCCDH. And there's my contact information if you would like to get in touch. And our three presenters today, Olga Milliken is with us in Ottawa, as is Jeff. Are you in Ottawa today, Jeff, or in Toronto?
Yes, I'm in Ottawa, I think.
And Olga is with the Public Health Association of Canada, as is Andrea Long. And Jeff has many affiliations, but the one that we've noted here is Health Quality Ontario. And I just wanted to give you a little bit of information about each of them. Olga, with the Public Health Agency of Canada, applies economics to tackle the burden of chronic disease. So this is work she's followed for some time. She works with international organizations to examine economic consequences and to evaluate policies. She's also writing on the economic impact of childhood obesity. And Olga has taught health, public, and international economics and published in primary health care. So Andrea Long, also with the Public Health Agency of Canada, came to this work after witnessing the importance of the concept of social determinants of health in previous work related to housing and homelessness, disability, poverty, and income insecurity. She continues to articulate the importance of using public policy to develop solutions. And outside of work, Andrea is an active volunteer and spends most of her free time growing food and riding horses. And Jeff, who shares this interest in farming, he notes most importantly he's a farmer, but he's held a number of leadership positions in medical education, among them presidency of the College of Physicians and Surgeons of Ontario and the Canadian Medical Association. In 2001, he helped establish Ottawa Inner City Health, which works to improve access to health care for people who are chronically homeless. Jeffrey also serves as the Chief of Staff at the Ottawa Hospital and as a National Medical Advisor for Correctional Service Canada. He's received numerous awards, including the Order of Canada. So the next slide, please. Well, I will move it. So this is just to situate the NCCDH for Determinants of Health. We're one of 6. We are located in Antigonish, Nova Scotia. And just to let you know that we focus on the socioeconomic conditions that influence health and the growing gap between least and most healthy. And our primary audience is public health, and we work to provide information to public health to help them in their work to address the social determinants of health. So in this webinar, we are going to look at evidence that links socioeconomic health inequalities and healthcare costs. And we hope that this webinar will spark dialogue in your locations about whether or not our healthcare dollars are being distributed in a way which is going to achieve that. I will present data about some of the macroeconomic forces affecting our health budgets. Then Andrea and Olga will show you data revealing the healthcare cost of socioeconomic health inequities, some longitudinal work. And Jeff will follow up by showing you how a holistic preventive approach has reduced healthcare costs for homeless people in Toronto. So the next slide. I just wanted to point out that we entered into this work about the economic costs of health inequalities through our 2014 environmental scan, in which we were told by our key informants that one of the key roles we could play would be to stimulate exactly this discussion. And then also there was a consortium of folks who got together in 2012 and looked at all the issues around economics and health inequalities, and they too, one of their key recommendations, and Danielle can put those resources up for you, was that the public also needed user-friendly data about the links between how we spend our healthcare dollars and health inequalities. So the next slide, this is the publication that we produced in response to that call. And one of the key decisions that we made was that we would focus on what could change in terms of the distribution of healthcare dollars. We know that this work involves many sectors: housing, transportation, education, finance, immigration, but we felt that the healthcare sector itself should look at how it could change the way that it's distributing dollars to address growing health inequities and pressures on the healthcare system. So the next slide is a poll. So we have to wait for Emma just to put up our that one. But I wonder if you could tell us whether your level of agreement with the statement, more of our healthcare dollars, so that healthcare dollars should go to work that creates healthy living, learning, and working environments. So we've got completely agreeing, outweighing. That's we don't have any don't agrees, which is interesting. Thank you. And the next slide is another poll. And Anna, if you just take that one down. So this is sort of a corollary of the previous question, but does this work creating healthy living, learning, and working environments belong to other sectors? So you have a yes, no, and health and other sectors, and I'm not sure there. But so I guess yes, representing it's not health work, and no, representing it is health work. And the third option being it belongs to all of us. So that's and I've just moved on to the next slide. So So I just wanted to clarify what we mean by upstream work. We use that term quite a lot at the NCCDH. And so what we mean by moving dollars upstream is work that goes to the fundamental social and economic structures that distribute wealth, power, opportunities, and decision making. And if you could just take the poll down, Anna. So these are translated. I have a list here. Some of these are arguably midstream, what we call midstream, and some of them are upstream, but they're these kinds of things. Moving dollars into areas that affect wages, reducing barriers to education, improving standards of housing, advocating with elected officials and for policy change, and working directly with clients in ways that improve their ability to access services. So now we're going to just switch. I'm just going to talk a little bit about why the concern about how we spend our healthcare dollars. So this first slide, which is 2008, some has changed a little bit, the data on this, but not significantly. But you can see in the shaded area that Canada is in the top 4 spenders among 17 OECD countries. So in 2008, we spent $4,079 per person on health care. That figure today is $6,100. So, in the last, what would that be, 7 years, it's increased by $2,000. But as you look down the line, you can see that we're 7th under life expectancy and 16th under infant mortality, which is just a stunning statistic. That is the statistic that has changed somewhat in the last 7 years, but not significantly. And then potential years of lost life. So that's looking at from people who died prematurely, what's the average loss in terms of what they would have been expected to live, and we're 12th on that. So basically indicating that we spend a lot of money, but we don't necessarily get the results from that. The next slide, this is a slide, I think, which is also from Kai Hai. It just indicates that we have climbed since 75 by 7% in the percentage of our dollars of our GDP that is spent on healthcare. And you can see that there's a leveling out and even a predicted drop in that percentage. And maybe some of you could speak to that more authoritatively than I can, but my understanding is some of it's generic drugs, some of it is austerity measures, and some of it is deterioration in services. Perhaps I could go out and say that there has been a recognition that this percentage of our GDP is climbing and that we need to do something about it. So our next slide. This is, I guess, where we can see more clearly the cost of healthcare resides with the provinces, and without exception, the percentage has climbed in all territories and provinces in Canada between, I guess, 11 and, some are smaller, 2%. The average right now is 38% of provincial budgets go to healthcare, and the C.D. Howe Institute in 2015 did a study and estimated that at current rates of increase by 2030, we would be spending 80% of our provincial budgets on healthcare. So at the provincial level, people are very concerned. So where are those dollars going? I'm on the next slide. Our total Canadian health spending, this is private and public, is $219 billion. An annual increase of 1.6% since 75, I guess, is where this was measured. You can see there that we now spend $6,000 and change on each individual, and that is 11% of GDP. So The next slide just shows, this is all information from the Kai-Hai report that I think Danielle has put up for you, but that we are spending 60% of that $209 billion goes to hospitals, drugs, and physicians, and you can see that physicians is where the cost of physician care is where the biggest cost is happening. And Jeff, you might correct me, but I think that's not necessarily more physicians, but increased salaries of physicians. So the next slide, I'm just going to show you a few slides that indicate what are the external pressures that are driving healthcare dollars up. So this first one actually is not showing the driving up, but what's showing is that we are, the predictions, this is the International Monetary Fund, is that our economic growth is slowing. So this is starting by saying we are way below our predictions of where economies would be in 2014. And this downward trend is what now a lot of the international economic thinkers are saying. So it's just indicating that we have fewer dollars to be spending on any of our government services. The next slide, another contributor to growing healthcare costs is the growing income and wealth gap, and we're going to see later in this presentation how this drives healthcare costs, but the simple message is the more money you have, the less costly you tend to be on the healthcare system. So the biggest drivers in our healthcare system are people in lower socioeconomic situations. So the next slide, some of you may be very familiar with Wilkinson and Pickett's work from 2012, just showing among, I think there's 21 European countries there, not all European, but they tracked, this graph shows the more unequal in economic status the country is, the higher the prevalence of a whole number of social and health concerns. So obesity is higher in countries where the economic gap is bigger, as is social mobility, as is homicide. Their work has been controversial, but it's also had a very large data base on which it was built. So the next slide, this is just to show you how the bars, the green, the orange, and the gray, represent high, average, and low socioeconomic status, and how the rates of hospitalization for each of those health conditions is higher for lower income individuals. So this is the concern with the wealth. And then there's the aging population, and there have been some interesting conversations around this, that in some ways this is not seen, Kai-Hai has not yet established that this is a driver for healthcare costs. However, when you look at our aging population, 17% of our population is 65 or older and predicted to grow to 20% by 2024. And then you look at the data on health care spending by age group, putting those two pieces together, it looks like something we need to be paying attention to. So the next slide. So this slide illustrates the rising rates of chronic disease. So over the years, you can see that the bars represent the hypertension, diabetes, cardiovascular. And then the horizontal line represents the year, and this data also shows that chronic disease rates are increasing, while at the same time our ability to mitigate, cure, maybe even, or respond to these conditions is getting better, which on the one hand is good and on the other hand is costly. So at this point, I will pass the slide and slide changing over to Andrea Long.
Karen,
Yes.
can you just give Anna 1 second? She didn't get a chance to mute the lines when the conference started because we were backed up from the fire drill. So if we could just give her like 10 seconds to mute the lines and unmute the presenters, then everyone else will be muted. So everyone's been very good to be quiet so far. Okay.
Hello, everybody. It's Andrea. Can you hear me now?
I can.
Okay. Then I guess I will assume that everything is working with the muting and unmuting. Thanks, Karen, for turning it over to Olga and to me. We appreciate the chance to be here today to talk about a research report that the Public Health Agency released in April of this year. You'll see on the cover slide there, which I believe is slide 26, that the report is called The Direct Economic Burden of Socioeconomic Health Inequalities in Canada, an Analysis of Healthcare Costs by Income Level. We realize that title can be a bit of a mouthful and might not make it clear to everybody what the report is exactly about. So I just wanted to really briefly note that effectively what the report does is provide an analysis of how healthcare expenditures are distributed across income groups in Canada. And we wanted to do that. It's important because it allowed us to then estimate the cost to the healthcare system of inequalities in those expenditures. So similar to the kinds of graphs that Karen was just showing about differences across income groups, we were looking at the cost of those differences for healthcare expenditures. So moving on to the next slide, slide 27. We wanted to talk a little bit about what motivated us to undertake this research. So in part, the idea grew from the report of the WHO Commission on the Social Determinants of Health. Probably many of you know that that report called for closing gaps in health between different population groups within a generation. And importantly, it also recognized that whole of government or cross-sector action on the root causes of ill health was critical to achieving that health goal. Around the same time, there was also increasing recognition that arguments that spoke about social justice in terms of health inequalities weren't proving to be sufficient to catalyze the kind of action that we wanted to see to reduce those inequalities. And that was leading to greater consideration of the potential that was provided by complementing social justice arguments with economic analysis in order to articulate the costs and the benefits of interventions in more dollars and cents terms. So developing that economic rationale for reducing health inequalities was also thought to be important for one other reason, well, at least one other reason, probably more. But it could provide an outcome measurement that is easily understood and used by different government departments and different sectors outside of health. And given that many social determinants are rooted in social and environmental and other factors that aren't within the control of the health sector, it's important to have that kind of accessible dialogue for all of those sectors involved in addressing social determinants. So from those starting points, the Public Health Agency and Statistics Canada and a very large and diverse group of partners started a dialogue on how could we begin to build a case, an economic case for acting on the social determinants of health. There's quite a long discussion and design process that we're not going to go into today, but what we ultimately settled on was that estimating the healthcare cost of health inequalities, what's also called the direct economic burden, would be a good starting point for this exercise. So this report is the result of that sort of initial research. But I did just want to note that, of course, healthcare costs aren't the other costs of inequalities. We know there are a range of other implications as well. This report doesn't go into that, but the Public Health Agency has supported some other researchers to explore other costs as well. So moving now on to the next slide on report objectives, which is slide 28. So the report had a few objectives. I'm just going to quickly go through them here. Sort of consistent with what I just described as the motivation, one objective was to contribute to addressing a key knowledge gap, which was the lack of economic analyses of health inequality specifically. Another objective was to develop and test research methods that allow healthcare costs to be linked to socioeconomic characteristics like income. That's all I'm going to say about that now, but Olga's going to speak a little bit more about the new methods that were used in this report. We wanted to generate the first national level estimate of the healthcare cost burden of socioeconomic health inequalities. We do have in Canada similar cost estimates for particular jurisdictions or for specific health conditions, but this report is the first pan-Canadian analysis. And last, we wanted to contribute just in general to building the evidence base on the impact of health inequalities in Canada, which, as I'm sure everyone around this table agrees, is important to inform decisions on public policy priorities and expenditures both inside and outside of the health sector. So I'm going to turn it over to Olga now, who's going to talk in more detail about the data and the methods and the results from this analysis, and then we'll talk a little bit at the end about implications as well.
Hello. Hello, everybody. It's Olga Milliken. Thank you, Andrea. Can everybody hear me? I'm waiting for somebody to type something. Thank you, Karen, also for the introduction. We are going to move to the next slides, and this is a picture of socioeconomic health inequalities in Canada. It's a bit difficult to see what's going on the slide, but basically, by socioeconomic health inequalities in Canada, we refer as systematically uneven distribution of health across socioeconomic population groups. And on the vertical axis, you can see health-adjusted life expectancy, which is the number of years expected to live in full health, given your age group. And on the horizontal axis, you could see age groups, and also you can see income groups. Income groups are from rated from 1 to 5. The fifth income group is the highest income group. So you can see here that for each age category, there is a gradient in health-adjusted life expectancy. Expected number of years in full health decrease with income. For example, if we look at the 1 to 4-year-old group, men in the lowest income group are expected to live 60 years. I don't know if you can see the cursor that I'm pointing to or not, compared to 70 years for men in the highest income quintile. So at birth, the gap for men is over 10 years in life expectancy in full health. And this is quite dramatic, I find. Please keep this picture in mind in your head, and when I further talk about the results on the distribution of healthcare costs across income groups in Canada. So next slide. So I'll talk a little bit about the data that's been collected by Statistics Canada. Only national level data are included in the report. However, provincial and territorial level data were compiled as well, and the data tables are available from us. A range of one of the challenges for investigating this relationship between the healthcare expenditures and the socioeconomic status in Canada is that there is no single source of data connecting with them. So for this reason, Statistics used various resources for a single year, 2007, 2008. So this project goes back. I started working on this project in 2010. And by that time, the data was already collected. So it's been a long journey. So cost data from 3 types of healthcare services were compiled together: acute healthcare hospitalizations, prescription medication, and physician, which is primary and specialist care services. These services were chosen because individual level data existed for them, and these services comprise about 25% or one quarter of all healthcare expenditures in Canada, which seems like a small proportion. However, these are important services, and this was the first attempt to compile the Canada-wide healthcare cost data by socioeconomic level. Some population groups were excluded from the data. These are institutionalized individuals, those in prisons and long-term care facilities, homeless, and people from remote communities and First Nations reserves. So the next slide, a little bit about methods. A bottom-up approach was used for the data compilation because it connects well individual level data on healthcare costs and income where possible, and then it aggregates. Other approaches are not suitable very well to connect income data with healthcare costs. Income was used as a proxy for socioeconomic status. There are other proxies, such as education and occupation, for example. What I want to point out is that the fact that there are differences in healthcare costs between income groups does not suggest that these differences are solely attributed to income differences. For example, healthcare cost estimates in this report are not adjusted for risk factors such as smoking. Healthcare cost estimates were grouped into nationally defined income quintiles. Each quintile represents 20% of the Canadian population. Next slide. Let's move to the results of this research. You can see here that there is a socioeconomic gradient in healthcare cost. The healthcare costs examined in this report generally decline as income rises. And this pattern holds for both women and men. However, this graph represents both men and women together. Gradient also holds almost for every healthcare cost group in this report, with high uncertainty for prescription medication costs, and you can see on the sort of yellowish columns represent the cost of prescribed medication, and you can see the whiskers, the confidence intervals around the estimates. So you can compare this picture with the your mental picture on health-adjusted life expectancy. You could see that the Canadian healthcare system works to serve those in a relatively poor health more than those in relatively good health. So we expect this pattern. Now, how was the direct economic burden calculated? So to calculate the burden, healthcare expenditures or cost of lower income quintiles were compared to that of the highest income quintile, quintile 5. And the direct economic burden is then a sum of the differences in age-standardized healthcare expenditures between the 5th and each of the other income quintiles. Using the best possible scenario here, which is the income quintile 5, the highest income personal income, as a comparator is a common approach in cost of illness studies. We here do not mean to say that the burden could be zero, that all health inequalities are avoidable, but the burden estimate in this report speaks to the magnitude of the cost associated with socioeconomic health inequalities, and it is significant for policy making. On the next slide, you could see how the burden was calculated. so the part of the columns above the horizontal line, which is leveled at the level of the highest income group. So all the part of the columns above represent the direct economic burden of socioeconomic health inequalities in Canada. And health inequalities are estimated to cost the healthcare system at least $6.2 billion annually in 2008 dollars. This exceeds the 2008 public sector health expenditures for each of 6 Canadian provinces. For example, in 2008, in the public sector health expenditures in Manitoba were $4.9 billion, Saskatchewan $4.1 billion, which is lower than this direct burden that's calculated here. This estimate represents the reduction in healthcare costs that could result if all Canadians had the same healthcare utilization and cost patterns as those in the highest income group. On the next slide, you could see the distribution of this burden. And you could see that Canadians in the lowest income quintile, quintile 1, have the highest healthcare costs and account for 60% of the healthcare cost burden. I'll say a little bit about the limitations of this study. First, I'd like to say that a number of health services were excluded from the data in this report. And it is important to note that excluded services are used differently by individuals from different income groups. And it's not always that high income costs use less. High income groups use less, not necessarily. However, overall, this was the best available data for Canada at the time of the report production. Also, the data is a snapshot of cost at a particular time. If we assess the lifetime healthcare costs for various income groups, the picture could potentially differ. Also, another point is that, so as we have data for a particular point of time, it shows only association between health and healthcare use and socioeconomic status. We do know that health status is influenced directly by socioeconomic status, but we do not know to what extent this is reflected in the data here. Also, the data in hand does not allow us to find out how other factors other than socioeconomic status influence healthcare utilization. This could be care access due to geographic location, health behaviors, and others. And these factors could also be linked to socioeconomic status. So further research in this area is required. And now I turn to Andrea again to speak about conclusions and implications.
Thanks, Olga. We just wanted to wrap up by talking a little bit about what we think the significance of this research is, particularly for our thinking about public policy investments. So on, what slide is this? Slide 37, you'll see a few points there. To begin with, although this has been well established, I think, in the other research that both Karen has described and some of the others have posted, this report does go some further distance to confirming that socioeconomic health inequalities do create a significant cost burden on Canadian society as a result of the higher healthcare expenditures that are incurred by those who tend to be more socioeconomically disadvantaged, in this case, who tend to have lower incomes. So the fact that data is available at the national level and we actually have costs attached to it is a first for Canada, and we think that's an important contribution in and of itself. Moving on from that to the second point, it's important to have a better and more concrete understanding of the cost burden because it does help to make clear the potential benefits of acting to reduce the underlying health inequalities that are driving these costs. Or to put it another way, the cost of socioeconomic health inequalities presented in the report is a starting point for putting a price tag on inaction, on choosing to tolerate health inequalities that are creating additional health care costs. So this is clearly an important consideration in how we shape our policy and programs to address social determinants of health, both within the health sector and outside of the health sector. The gradient that Olga highlighted in an earlier slide around healthcare costs also underscores the way in which health inequalities are rooted in the underlying social determinants of health, the differential access and exposure to underlying social, economic, and environmental factors, all of which we know importantly shape our health. And although we saw in the pie chart that Olga showed, a disproportionate share of that cost burden is incurred by Canadians with the lowest income, so those in the bottom 20% of the population. Another key lesson of the gradient is that it does illustrate that this cost burden is distributed across all income groups in Canadian society. So although it's tempting to think we might be able to address socioeconomic health inequalities by targeting additional supports just to those at the bottom, those who might be considered to be most vulnerable, the gradient does remind us that these are really population-level problems and that we do need to think at a population level if we're going to address them. So finally, we just wanted to note that understanding the direct economic burden of socioeconomic health inequalities can help to inform decisions on the balance, how we balance our expenditures between prevention and treatment within the healthcare sector, but also balancing our investments in health versus other social supports that we know facilitate healthy lifestyle contexts and choices. And that kind of goes back to some of Karen's introductory points around the proportion of spending in provinces and territories on health versus money left over for other social services. So despite the fact that there are limitations to the burden estimate, as Olga noted, from this first step in the research, it does provide a good indication of the magnitude of the costs associated with health inequalities. And I think we think that even without the benefit of sort of more comprehensive data and being able to include all population groups, this magnitude is really big enough to underscore that health inequalities are an important consideration of policy development and that efforts to reduce them really have potential to yield solid results. So eliminating health inequalities or reducing health inequalities can be accomplished by programs and policies that promote health and prevent illness and disease, and by pursuing policies targeted to the root causes of health inequalities, the social determinants. And we definitely talk in the research that while this report motivates the need for that better understanding, more work is needed to look at the costs and benefits of specific policies and interventions that can actually effectively address these social determinants of health. So certainly it's a case for using this research to motivate a stronger understanding in that area. So that's what we wanted to conclude with, Karen. So I will turn it back to you to move on to, if we're going to have questions now, or move on to Jeff's presentation.
Or Andrea, are you able to, there's more detail I imagine in the report, and Danielle put up the link to your report.
I'm good. I'm not on the phone. I'm on it's a webinar, the online. How are you? Good.
Hey. Well, there are some lines that aren't muted that probably should be muted, so, or maybe Andrew. So, Olga, do you want to respond to that question about method?
Sorry, what question?
It's the question you answered in the chat line, but it was a question from Olympia about just Somebody's on there.
Hello?
Okay.
Hello, everybody. Can you hear me?
Yes.
I guess my line is muted. But you can hear me here? Okay. So I think we're back on. Everybody can hear. So, Olga, maybe you could respond. This is the email. You could go to either Andrea or Olga's emails to get more about methodology information. And I just wanted to catch some of the other questions. R. Edwards has asked, are sick people more poor or poor people more sick? Does anybody, Jeff or anybody, want to respond to that one?
Perhaps I'll begin because I see this on a regular basis. I think there's definitely, it's a two-way street. We take people who are poor, who gravitate to circumstances that make them sicker, and certainly people in our society who have disabilities and illness also become sick. So poverty generates poor health, and poor health generates poverty.
Yeah, it's sort of those layers of outcomes and consequences, isn't it? Yeah, thank you, Jeff. And then we had one other, where would you be able to, from Scott Leon, where would I be able to get the data tables that Olga mentioned? And I imagine, Andrea or Olga, could you respond to that one?
Hi, yeah, it's Andrea. I can respond to that. And I notice at least one other person has asked that in the chat as well. So, yep, please just, our email addresses are up there, Olga's and mine, and we're happy to send the data tables with you. They're not posted anywhere for a number of reasons at this point, but they can be shared, and they provide data basically for 5 different sets of research questions around cost of services, as well as around the health-adjusted life expectancy that Olga spoke about in her early slides. So happy to send those to you or to anyone else if they'd like them.
Thanks, Andrea. And then there was one final question, which was from Mark Andrew. How does socioeconomic status influence the use of preventative healthcare services? And he's given the example of vaccination or screening. So does anybody have a sense of that one?
My prediction, it's Olga, that it's lower than average, but I'd like to see the data on this. I don't know if Ontario did research in this area, so I simply, I'm wondering too.
That it would be that those preventative services would be accessed at a lower rate by people from lower
I would imagine
SES categories. Okay, so I will just to move us on at this point. Andrea, at the end of her chat, just mentioned that we do not have sufficient evidence linking policy or interventions with changes in health
care expenditures, and certainly in the work we did, that's very true. While there's lots of studies that link health outcomes, there's not a cost figure put to it. So I'm just going to show you two studies who have been trying to do this work, and this is the Housing First study, and just showing, so it's you can see the Housing First folks had an immediate drop in ER visits that leveled out with the treatment as usual group over time. But in terms of the outpatient use, the Housing First group dropped significantly, and that gap continued with the treatment as usual. And this Housing First is an initiative that is being done with Canada Mental Health Services, and so the idea of Housing First is if you provide housing, a lot of the other implications of around mental illness go down. So that was one study, and these are all referenced in our work. And then the other piece of very commendable work is being done by Valerie Parasyk and her colleagues at the University of Toronto, I think, where she has actually shown figures, and there are I'm sorry, I've had to change computers because of our technical glitch, and I haven't got my notes, but if you look up her study, you will see that she's actually brought percentages of how changing people's food security level drops their health care costs, and she's done this at different levels. So she's actually looked at costs around food security and how that can change around initiatives. So I think that's it for me, and I would like to, one poll, if you would like to answer this, and Anna will put it up. Our provincial health ministers should negotiate a healthcare accord that scales up public health solutions that prevent illness and injury from happening in the first place. So as we know, the healthcare accord is not necessarily big on preventive initiatives, and if you could just give us a sense of how you feel about that. This is perhaps where we see that we're preaching to the converted, but it also might be that the public is ahead of our politicians' thinking. Thanks very much, everybody, and I'll just move on to the next slide. We'll send you the results of these polls. And one more. So we just wanted a sense of why does such a small percentage of healthcare dollars go to prevention and health promotion? So you can choose more than one of those, and then I'll put the poll up. And if you have another, maybe you could write into the chat box. So yeah, please, if you have some thoughts of some other reasons why health prevention and promotion are not politically bigger contenders in healthcare debates, let us know. Okay, so I will now move to Jeff, Dr. Turnbull, if you would talk to us about the work you're involved with.
Sure, it's a pleasure. Thank you very much. I'm going to assume that people can hear me. So what I'd like to do is the really good work that's already been done that you've heard all about, and that looks at cost expenditures and the association in health and poverty, and then move that down to a provincial and then actually down to a local opportunity to show you where you can actually save money and provide better care, and so that by addressing these inequities. So let me begin by, so that's my title, and I want to speak from the perspective of several perspectives. One is the Chief of Clinical Quality for Health Quality Ontario, so that allows me to speak about provincial equity initiatives through Health Quality Ontario, but also the Chief of Staff of the hospital. So if you looked at those, the people who were spending the most amount of money in our healthcare system, hospitals at around 30%, and then physicians around 16%. So I probably represent the majority of the problems that are out there in the healthcare system. So I guess I could speak very well from the source of some of those problems. My hospital has a budget of $1.2 billion. It's one of the biggest hospitals in Canada, but nevertheless, could that money be redirected elsewhere in a more effective way, promoting health and better health care for our communities? And then I also wanted to speak from the perspective of somebody who's been involved in developing a health mitigation strategy for the homeless, and I'll try and explain that in a moment. So let's think about provincially. The Health Quality Ontario became seized with the need to talk about health equity, and I'll describe that in a minute. But here's what from our perspective, we're talking about health and healthcare equity. In that context, this is a diagram of two young fellows, both in Ontario. Both should be accorded the same rights and privileges as any other resident of Ontario. But the reality is that these two individuals can expect very, very different health parameters and health outcomes. The fellow on your left, that person's going to probably live 6 to 8 years longer than the person on the right. The person on the right is likely is about a 4-fold increase in diabetes, and about a 2-fold increase in addictions, mental health, trauma, disability, smoking rates, etc., all dramatically higher. So higher risks and worse outcomes. And these outcomes, I think it's important to recognize, well, might be related to poverty, could be related to other factors, socioeconomically, sort of rural remote settings, indigenous settings, sexuality, refugees. So massive health inequities arise as a result of social inequity. And in Health Quality Ontario, we're just turning our attention to that. And so the definition in the middle there, basically, that probably nobody can read, is health equity allows people to reach their full health potential and receive high-quality care that is fair, appropriate to them and their needs, no matter of where they are, where they live, or what they have. So that's the goal, and I'm just going to briefly talk a little bit more about in Health Quality Ontario, where we're trying to think about the context of between health and health care, and where does equity play an important role within that context. So clearly there has to be equity in access. So right care, right time, right place for the right person. Easy to say, but exceptionally difficult to provide, and I must admit, under most circumstances within my context, caring for the homeless, we don't, even though health services may be available here in Ottawa, they're certainly not accessible by our homeless community, and in many circumstances they're not acceptable to our homeless community. So there are populations that are vulnerable and disadvantaged who don't even have routine access to the usual health services that we would all anticipate. So for example, in my setting, no one of my homeless individuals will ever get on a wait list, no matter how long that wait list is, for a total knee joint replacement. If they're homeless, the practicality of getting onto a wait list waiting for that period of time, and then still being available 2 years later to actually have surgery and be accepted for surgery, it's just not going to happen. So yes, Ottawa has total knee joint replacements and orthopedic surgeons, but it's not accessible to that community. Then the next thing is equity in terms of outcomes. So if you have a stroke in downtown Ottawa or Toronto, you're within minutes of a stroke protocol where you'll get thrombolytics or interventional neuroradiology to remove your clot. If you happen to be in a rural and remote setting, that access to immediate services might be as much as 24 hours, and we know that if it's within 3 hours, you'll get good outcomes. Anything beyond that, you'll have very poor outcomes. So that stroke and the recovery from that stroke in a rural and remote setting is going to have an exceptionally different outcome than if you happen to be more advantaged by living in a broader urban center where there's access to those facilities. And then lastly, equity in health. That's any child born today has the same health potential, no matter where they are, who they are, and what they have. That is, we are so far from that. It's very, very significant. And so just to give you some ideas of the magnitude that we're looking at of inequity, I work in Bangladesh, I work in Eastern Africa and the Balkans, and many of the health indicators from our disadvantaged populations are comparable to the developing world. TB rates, rural Bangladesh versus indigenous populations on reserve, higher on reserve than they are in rural Bangladesh. Lung cancer rates in our Inuit population, highest on the planet. HIV rates in my injection drug using population, that population about 21%. Sub-Saharan Africa, anywhere from 20% to 35%. So massive health inequities and differences. And even if you look at some subgroups, we will look in the earlier presentation at the lowest socioeconomic bracket, but if there are subgroups even within the lowest socioeconomic bracket, so the homeless, if you go from the most advantaged, wealthy community of Hamilton and you go to the poorest community of Hamilton, about 15, 20-minute drive, life expectancy drops 21 years. Basically, these are massive differences. Over the last 100 years, life expectancy in Ontario has gone up by 20 years with all of the technologic advances and the advances of our improved way of living. That community, that advantage has basically been lost totally. They haven't experienced any of that benefit because their life expectancy is the same as it was 100 years ago. So my point here is that these massive socioeconomic variables are having massive effects on the health of our communities. And I would make the argument that it makes very good sense from a professional values. It's good health care, good health that we get involved in this. I think there's a very strong human rights argument that these are rights that should be accorded to all citizens of Ontario or any other province. And then we've heard the argument that really you can't afford not to fix this problem. And we've seen that social inequity is growing dramatically in Canada, and as a consequence, we're seeing the side effects of that, of growing health inequity. This is Health Quality Ontario's placemat or reminder, if you will, of where the different principles of equity are, or of quality are. And you can see that we've moved from safe care, that was an initial priority for the quality movement. We then tried to look at the issues of access, and so that was timely care, then sustainability of our healthcare system with effective and efficient care. More recently, we're looking at patient-centered care. But at the bottom, Everybody now would recognize that you cannot have a quality healthcare system unless it's equitable. So equity has become one of the foundations for a quality healthcare system and the overall improvement of health for our communities. And as a result of that, Health Quality Ontario has embarked upon an important initiative that really it promotes equity in all of the work that they do, all of their goods and services, and also helps, is now designed to work with all of their partners throughout Ontario to promote equity in all of the other agencies and organizations that serve our community through the healthcare system. And in doing that, they've recognized, however, that in its own self will be a challenge, but it's insufficient to address the broader challenges. And so the need to reach out to other sectors that are beyond the healthcare system to solve this problem. And so that's the direction that Health Quality Ontario is taking. And we've been really gratified with all of the other, to see all of the enthusiasm and hard work that other organizations are doing. So I think that there's a recognition that the time is right to really focus on health and healthcare equity. Now, I'd like to now turn to a much more sort of local area, and as we try and address one unique population that I care for, this is my clinical practice, and that's the homeless. And just to give you a sense that moving down to a micro level, the practice level, you can actually make very, very significant improvements in the overall quality of people's lives and their health and health care just by simple interventions that actually give better outcomes and save money. And so here, let me give you that example of homelessness. So we know that those people in the homeless environment, they're poorer. They have a poorer age-adjusted mortality rate between 4 and 10 times. I've mentioned that. Likelihood in an Ontario homeless shelter getting to the age of 75 is only 25%. I've talked to you about HIV rates. Hep C rates in my injection drug users about 80%. And they rate their health poor, and they have much more, a higher prevalence of chronic diseases. So we know that the health of the homeless is not at all good. They have a high predominance of mental health and addictions and chronic diseases. But they also have a huge impact on the healthcare system. They have a higher burden of disease, as I mentioned, greater exposure, they lack resources, and their circumstances prevent them from accessing the usual preventative or the usual even primary care. They live in a world of crisis, and they access the emergency department, crisis services, ambulance services, police services inappropriately. And so as a result of this, their health is not getting better, yet they're utilizing enormous amounts of resources. So one of my homeless individuals was, before entering into the program, was in our emergency department 191 times in the 6 months before coming into the program. So if you think about it, and many of you are probably doing the math right now, that's pretty well a full-time job to get intoxicated enough to be picked up by an ambulance, taken up to the emergency department, tie up the ambulance for about 3 or 4 hours while they're waiting to offload, be seen in the emergency department, detox enough to actually discharge yourself, and then go back and do it again. And the cost of that is massive. Our colleagues in Toronto estimated the average cost of a chronically homeless person in healthcare and judicial services to be between $175,000 and $225,000 per person per year of the chronically homeless. So think that every night in our homeless shelters here in Ottawa, one city, we have 1,000. So now you can start to get an idea of the magnitude of the cost of the healthcare system and other systems involved. So this is not just an argument of improving the overall quality of services and outcomes for health, but it's an economic argument as well. So if you look at those people with the high cost, high users, we know that the 5% who utilize a very significant part of our healthcare expenditures, Who are they? Well, we've now recognized, if you look at their characteristics of that population, they lack resources, access to effective care and entitlements. Their care is fragmented, episodic, crisis-driven, as I mentioned. They're often vulnerable, isolated, and voiceless. And one thing that unifies many of them is that they're poor. And so that population are utilizing health services ineffectively at a great risk, at a great cost. Parenthetically, I also worry about not just the high users, but I worry also about the low cost, high needs populations who are going under the radar and getting no services. So I'm going to quickly go through some of these issues just to tell you briefly what we've done. We've recognized that if we're going to provide services for this population, we have to reach out to them and provide services on their terms in the community. And this is an area where the hospital and the community has gotten together, and we actually have moved hospital and primary care-based services out into the shelter environment. We defined our community. We considered systems-based processes and programs to solve that. We did it on their terms, and we've, in the context of that, tried to work on all of those other social factors that were making them so vulnerable. And I'll just briefly tell you about how we did. Just to go through this quickly, we have a very high percentage of homeless in the city. We have, as I mentioned, about 1,000 every night. And it's moved from the domain of the adult male alcoholic to women, family, children. So it's a very different group. And issues now such as heroin, crack cocaine, prescription opioids, profound mental health and addictions is always a challenge for us. They face these, when we met with them, they said, these are our challenges to care, and they identified them, and we said, okay, if we're going to build a system for care based on that, we're going to have to resolve these problems. And then that led to Inner City Health, which is this integrated health system for our homeless within Ottawa. And this gives you some idea of what we started off very small, 30 to 40 beds, has now grown to a much broader program, about the size of a moderate hospital. And you can see that we have beds in shelters throughout the city. We now own 4 hotels as people have progressed through the programs and now need supportive housing. And so we're out throughout the city getting people from fields or under bridges, but at the same time getting them into a shelter environment and then moving from shelter environment out into supportive housing. I did rounds just this week, and we had 245 patients within the program. So we go out, as I've said. This is a picture of where we go out with nurses, personal support workers, peer workers, and a few physicians. We provide those services throughout the whole community, primarily in shelters or independent housing, which we now own. We do it on their terms. Every client has a case management approach, what their goals are, how they want to be cared for, and where they want to direct our energies and their energies. And we wrap around support services for that, and we try and mitigate the social determinants around them. It's definitely team-based. We have new partners, people that we've never been used to working with, from judges, police officers, housing people. I probably spend on rounds a lot more time, very little time talking about TB or HIV, but the majority of time is talking about all those ancillary support services that we have to do to getting them entitlements, addressing financial inequity, getting them transportation, reconnecting with families, etc. This just gives you an idea. If you're going to get into this business, you're going to have multiple partners and this is the members of our board. So we have a wide variety of community participation. And then we have to try and solve their their sources of inequity that they deal with on a regular daily basis. And then let me just finish with 2 slides just to say, has this been cost effective? Does it actually improve overall outcomes? So providing integrated services that address the social determinants and address their needs based on the services that they want, when and where. We actually, net of our expenses for the whole program, provide those services to 240 clients per day. And with that, we save the healthcare system, just the healthcare system, about $3.5 million a year. So, but do we get better outcomes? All of our, we had an external review, all of our health outcomes were superior. Compliance to medications, compliance to Canadian guidelines in health service delivery, immunization, screening, self-care, addictions management, all were better and actually very comparable to the housed environment populations, and in sometimes certainly exceeded that of the housed population. I'm going to end with just one last little note, is just to say that we started this program, TED, and that's to divert people from the emergency department, and that's been very, very successful in doing that. We've actually had 5,300 diversions of people that would go to the emergency department or be picked up by the police, and that saves about $1.7 million per year. So I'm going to stop at that and then turn to the others for any questions that they might have.
Thank you so much, Jeff. That is such impressive data, I guess, let alone the kinds of work that goes into those collaborations. But the dollar savings, I certainly hope, and I take heart from the fact that you're well placed to communicate that information, might influence policy down the road. There's a couple of questions. You want the one from Mark Andrew, Devil's Advocate question: wouldn't we have a bigger impact on health at less cost to give homes to the homeless, a housing first approach, than to provide outreach primary care to those who are homeless?
So Mark, Andrea, I would agree totally. So what we came to your solution late. We started off thinking about health care, and then we said we couldn't really solve this problem until we had them in a stable housed environment, and that's why we've now built or bought 4 apartment buildings. And so that's a housed environment and a home first approach, and I think that's an excellent approach. I would caution, however, in my community, though, it has to be supportive housing. Housing on its own right, just housing, I don't think in my community of homeless who have been chronically homeless with mental health and addiction problems, that probably would not be successful, but supportive housing absolutely is the solution.
Thanks, Jeff. And perhaps you'd like to read the question from Allison there?
Sure. Jeff, what type of advocacy efforts is your group doing? E.g. political advocacy, things such as housing, social assistance rates, etc. I think the advocacy challenge that we all face is that, well, certainly we're as vocal as we can be. We are vocal at a community level, municipal level, and a provincial level. The challenge we all face, I think, is that we're so busy running on a day-to-day basis to maintain services that we don't have a chance to draw our breath and speak out. I have to say now, this program, elements of this program have now been incorporated in 3 or 4 other cities in Canada, in Ontario, and then in other cities in Canada. I'm just trying to 4 cities in the United States, all of the Netherlands. Al Jazeera is coming to visit us now, So we've got, there's been a lot of attention internationally.
Thank you. And there's a question there from Edwards, last name. Where do the savings go? One challenge has been, that potential collaborators don't share the financial benefits of savings.
Yeah, great question. The savings disappear, and the savings, unfortunately, don't get reinvested into the program. We should have been smart and said right at the beginning, if we'll take 50% of all savings and reinvest into the community. But as a result, savings go back to ambulance services, savings go back to the police department, and savings go back to the hospital. Yet we all know those savings should have gone back into upstream solutions.
And please go ahead, Jeff, with there's Chris Kobus has a question there.
I'm looking for Chris. I see Chris saying, thank you, excellent presentation.
And just scroll down.
So, any suggestion on how to heighten the urgency of this model of care for those not yet homeless but impacted greatly by social determinants? Yeah, so I think this is generalizable to other environments, and I think that we've started to recognize that we're just dealing with one group of people who are so profoundly affected by the social determinants that we need to, I wish we could move upstream a bit. So we've started to identify high-risk communities that have not been impacted by homelessness, because once you're in a homeless environment for 6 months, it's very, very hard to repatriate that person back into an education, back into work, or back into their home community setting with their family. So how do we identify high-risk populations? So the risk group population that we're looking at the moment are the young children who come into a shelter environment, 15, 16 years old, high risk, addictions, and mental health challenges, and often abuse at home. And how do we get them out of a shelter environment before they actually suffer all the consequences of that high-risk environment? So a really good question. We have to move upstream and identify people who present themselves with risk and get them before they get unwell.
Thank you. And then Marcella Tapia has just asked your thoughts on basic income guarantee as a upstream approach.
So I think I think I'm very much in support of that as an investigative trial. I think there has been experiments about this in Canada and Dolphin, but in other settings as well where it's been shown to be helpful. I very much support that. I think that would be a very wise investment in terms of reducing subsequent social services demand and health services demand. But I personally don't think, from my perspective, we need new money. I think there's money already in the system. It's been spent, unfortunately, as a consequence of these social determinants in an acute hospital environment, $1.2 billion a year in my hospital. But putting somebody in a prison at $155,000 per year, this is a very expensive solution for a problem, one where, in fact, you're probably not solving the problem.
Thank you. Thanks. Those statistics, and there is, Corinne just mentions there's a guaranteed annual income. I think that's Peel, is it, Jeff? Do you know? There's a pilot right now that...
I think this is just got up and running from what I understand, but Corinne might know better.
Yeah, I'm not sure. I know Peel Public Health has certainly come strongly out in support of a pilot going, and I'm not sure if they actually got the money. So
Corinne is typing.
Yeah, so R. Edwards says that what was called Health Links, so that's an initiative of the Ontario government, focused on the 5% and in some cases began to look upstream to prevent ER visits. So
Yeah,
I don't know if any...
I could comment on that because that health links are run by Health Quality Ontario. So exactly, that's a great point. Those were programs that were looked at to invest strategically into the 5% high users. They had 4 or more chronic diseases. Interestingly, when we look at those and we look at the groups that are very, very successful, 2 things came out. One was if you wanted to really be successful, you had to start to look at other factors other than healthcare to make them successful, such as housing, transportation, etc. And the health links that were, when you look at them globally, the ones that did the best were ones where they served high-income groups. And the ones that did the poorest, the ones who served the lowest income groups.
This is the repeated story of who benefits from universal programs right across the board, it seems. Thank you, Jeff.
So smart people, well-educated, bright, and they can navigate a system. They don't have to, they can advocate for themselves very, very well, and they move very quickly into programs that may or may not have been targeted for them. But if there's an improved access to services, bright, well-educated people will move quickly to them.
Mm-hmm. Yeah. So another level of the action of the determinants on health outcomes. So we have, thank you so much, Jeff, and as we suspected, your presentation, which is so grounded in practice, would garner a lot of questions. We had one polling question to ask you. Assume that Canada's health budget is $100 billion, and currently 10% is spent on health prevention and promotion, and 90% on healthcare services. How much are you prepared to take from healthcare services to bolster prevention and promotion work? So this is a hypothetical question, but if you could give us a sense of whether you think there is room within the healthcare budget for this kind of movement. Mm-hmm. So, yeah. So there's support within this group for at least some shifting of monies within, and maybe, Jeff, that discussion about where do the savings go might address some of that.
Right. And I think in response to this, you should understand my hospital today is 117% occupied. We have 56 people in the emergency department admitted with no beds. But at the same time, we have 148 patients waiting to go into long-term care. So those are people who would get better care at a fraction of the price somewhere else. And we know it would be better. So my hospital today will spend probably $170,000, one hospital, on those individuals who could get cheaper, better care elsewhere. So it's not as if there's you don't have to cut quality. If we only had a better system, and frankly, a lot of those people in the hospital right now would have problems with social determinants of health. The majority are poor and are dealing with the consequences of their poverty. So somehow we have to invest strategically into the upstream solutions to relieve the congestion in the acute care hospital-based sector.
So that is our time for today, and I just want to thank everybody who participated with questions. There are a few more at the end, and we'll have a discussion with the presenters. We'll try to get answers back to those of you who weren't able to have your questions answered during the time of this webinar. It will be up on the NCCDH website, both an audio tape of our discussion and the slides, so we will let you know about that, and we'll be sending you out an evaluation form very shortly to get your feedback on this webinar. And so I would just like to close by thanking very much Andrea Long and Olga Milliken and Jeff Turnbull for their contributions to this webinar. It's a wonderful discussion and many-faceted, and definitely, while we need more evidence, there's enough evidence for plausibility there for us to start making some changes. So thank you, everybody. And if I could just ask the presenters to stay online just for a few minutes to have a quick debrief. But thanks, everybody, very much.
Thank you.